Welcome to Monday Scoop. I'm Georgia Raisman, and on Monday Scoop, I have short conversations with a variety of experts on issues affecting people over age 55. Whether it's food, health, style, or entertainment, we'll explore ways to lead better and deeper lives as we get older. This is Georgia Raisman, and I'm here on Monday Scoop with a good friend and very accomplished doctor, Dr. Jeff Drazen. He's the distinguished Parker B. Francis Professor of Medicine at the Harvard Medical School and Senior Physician and Chief of Pulmonology at Brigham and Women's Hospital in Boston. For almost 20 years, until September 2019, he also served as Editor-in-Chief of the New England Journal of Medicine, the most prestigious medical journal in America, if not the world. At the New England Journal of Medicine, Dr. Drazen favored the publication of medical research based on randomized controlled trials. Using that information enables doctors in everyday practice to improve their patient care with better results for all of us. So Jeff, tell me a little bit about yourself and how you got into medicine.
So my father was an electrical engineer, but he brought electricity to rural areas of Missouri. So you'd have a farmer that had some electricity. They'd have a radio and maybe some lights in the kitchen, but they didn't have the power they needed to put in pumps and milking machines to turn farming from a subsistence living into a commercial living. And in the late 1940s and 1950s, my father was involved in taking electricity that was left over from the Tennessee Valley Authority, because they used it to make the atomic bomb, but they didn't need that anymore, distribute it in that area of Missouri. And one of the things that I learned from him was that you could change people's lives in a positive way through science and technology. And in fact, when he would come back to a community where they had put in electricity, they would be treated like heroes, because in fact he had made this people's lives much better.
So it was an early example of putting science to work.
Technology and science made a positive difference. But also, I like to work in a way that made people's lives better. So when I went to Tufts College as an electrical engineer and physics major, but during that time, I had a need to connect with people. And so I worked with some kids who lived in Somerville, who were from a fairly poor neighborhood, and once or twice a week we would get together and hang out. I was 20 and they were 15 or 14. And we hung out together, and that personal connection was really important to me. It wasn't just the numbers.
You could make that personal connection with such disparate backgrounds. I mean, to hang out with kids in Somerville.
It's easy to hang out with somebody if you're interested in them. And I think that was the key. I learned a lot about them. And it was good for me, and it was good for them. And as an aside, we had a reunion about 15 years ago, and every one of those kids had done good.
That's fabulous.
They had real solid jobs. One of them had won the lottery and bought a place out in Billerica. Another got a job and then eventually bought a dump truck and worked the big dig. And it was wonderful to see these kids succeed. It wasn't through science, it was through human connection, but I think you need both. You need to have...
You stayed in touch with them after all those years.
Yes.
That's got to be 40 years later.
Yes, right.
Pardon me for pointing that out.
But we had a good time, and I think for many of them, it was a big brother, father figure, someone that they could relate to who wasn't part of their daily life.
And who believed in them.
Right.
Who believed they could be something.
The first date I took my current wife and my only wife, Erica, on was to a party that the kids had put on after they painted the room where we worked. So it was a fun thing to do, but it was a combination of science where I was studying the Hall effect in zinc selenide crystals as a thesis project during my last years of college, and having these kids was a good intersection. So I decided to go to medical school because one of my advisors told me that, I wasn't an Einstein, and even if I was really smart, I'd end up teaching physics at some college somewhere and probably wouldn't influence a lot of people's lives. So if you wanted to influence lives, you should really go into medicine.
That was good advice. That was
took
good
the advice and I went to Harvard Medical School. And at Harvard, in my second year, we had courses that you could take that were elective. We don't have that anymore, but back in 1969 they did. And I took a course in respiration physiology that was taught by a very charismatic man, Jeremiah Mead.
And respiration physiology is how our lungs work to help us breathe.
It was the study of the science of breathing. But what made it different from all the other courses I'd taken in medical school is that these people were using equations to describe how we breathe. And finally, you know, for a guy for whom an equation is an answer, now I like to say that for me, differential equations were a solution and not a problem. Finally, I had a solution that fit me. I could use the mathematical skills that I had learned in undergraduate school in medicine. And so I went to see the guy who was teaching the class, and I said to Professor Mead, I want to be a respiration physiologist. And he said, no, you don't. He said, you want to learn physiology and use it to study a problem in medicine.
And your phrase is, science is important because it leads to knowledge, and knowledge is important, research is important, and research leads to practical uses. That makes life better for people.
Yes, and it has to be turned into practical. It doesn't happen on its own.
That's true.
And the applied scientist, that's what I view myself as, takes basic understanding and turns it into things that can change people's lives. And a basic scientist is kind of only interested in figuring out how things work, and then that's somebody else's problem. And I like to take that thing where they figured out how things work and say, how can we use that in a way that makes a positive difference?
Well, what you've done with that is you've made a difference in a lot of people's lives, and even in my children's lives, because what you worked on helped develop this drug called Singulair, which is a heavily, widely used drug and helps people with asthma because it clears up the cells in their breathing apparatus, I mean, to put it simply. Am I right?
Yes, you are. So remember that Mead, my advisor, said you should need to study something, and the two problems he suggested were asthma and the control of breathing during sleep. Well, I wasn't really all interested in sleep, so I got into studying asthma and developed methods for studying how things that your body produces can lead to adverse effects. And in asthma, you have your airways, so your lungs like a tree, and the big branches are, for reasons that only God knows, when she was building us, put muscle around those things, and it constricts, and when you have an asthma attack, that muscle narrows. So in the late 1960s, early 1970s, the question was, what was it that was causing it to narrow like that? And there was kind of a worldwide race to try to understand that and find the chemicals that did it. I was involved in the race, but the guy who won it actually was a Swede, Bengt Samuelsson. He got the Nobel Prize in 1982 for that work. But having identified what that was, we were then able to work with people who could make it instead of having the body make it, and understand how it worked to cause airways to narrow, and with that, how to develop things that would prevent that from happening. You
know, that leads me to the next topic I really wanted to talk about, which was we have so many people who have a kind of an anti-pharma attitude these days, which is anti-big pharma attitude, which is like, why do we need these big companies and they charge us so much money for drugs, and they're all, you know, we should all be using herbs. Forget that. But big pharma has a role to play, because after you and scientists have developed a drug that works on a level that you understand, somebody has to take that and make it into something that the patient down the road can use. And that process is very complicated and very expensive and very elaborate and very time consuming, and you need a lot of scientists that you're paying for, and a lot of tests that have to take place along the way, and somebody's got to pay for that at some point, and big pharma is who pays for it while it happens.
So the one adjective you left out was very risky.
Risky.
And so you have an idea, and the tests in humans see whether what works in the test tube, what works in mice, what works in mouse, what works in monkeys, can work in man. And most importantly, does it cause side effects, that would
right.
limit its use.
So all of those large-scale tests that take place at different levels are to make sure many of them are to make sure there are no side effects that are not bearable.
Right. Well, it depends on the condition, right? If you have cancer that's going to kill you, you'll put up with a lot more side effects than if you have asthma that many people view as a nuisance.
Right.
And so that there's always this balance. Are you going to take the drug for a short period of time, like you will for an infection, and then stop it? Or will you be on it for months and years for a condition that we can't alter the basic biology, but we can prevent it from making your life miserable?
Right.
And so those are the kinds of questions that really can only be answered from very expensive, very well-designed, large, long-term human experiments. Those cost a lot of money to do.
They cost a lot of money to do, yeah.
And sometimes you do them and you don't get the answer you want.
Yeah, and then you've invested all that time and money and human effort in a drug that's never going to come to market, and you start over again with drug B.
And you can't, in good conscience, use that drug if in fact it has serious side effects. So it's to some extent a risky business. Now, my sense was that this was going on, and in the 1980s and 1990s, drug companies were run by scientists and physicians. And they were having a good time making medicines that made people's lives better. Their primary goal was just that. They weren't into making money. In the 1990s and early 2000s, a lot of people got out of business school with no biological background and started working for the drug companies. And pretty soon, there was a subtle but very important change. Drug companies decided their primary goal was to make money, and that they were going to do that by making drugs that help people. And that would be okay if you remembered that your primary goal is to make drugs to help people and you wanted to make some money at it. But Wall Street demands high returns on your investments. And suddenly, what they were investing in these highly risky trials, in order to pay off, required a very high payoff at the end. And I think that our marketplace has driven us to do this. Now, I don't have a better way out of it, but it certainly
an attitude change.
It certainly is a problem, and I think it's expectation problem. That the people on Wall Street, the finance people, expect a big return, but the population using the drug wants something affordable. So where's our happy medium? I think that that's something that's going to require some serious introspection, and both the shareholders and the executives at drug companies have said, should we be a little less profitable, but more people friendly? And I think that is a question that's sort of beyond me, but one that's worth pondering.
And maybe one that society as a whole, social influence and social opinion will have to sort of start to influence. Well, let's get to COVID-19, because that sort of is another thing where big pharma plays a role. Somebody has got to develop a vaccine. Well, how do you think we're going to get out of this horrible mess that we're in?
I think it's been very interesting to watch. I've been watching this actually since early January. We heard about this respiratory illness in Hunan.
You did?
And and we were paying attention to it. And then on the 23rd of January in the New England Journal of Medicine, we published an article that said that somebody who was asymptomatic, she may have been mildly symptomatic, was able to transmit the disease.
That's terrifying.
And when I learned that, I said, this is going to be bad. Because if usually with an illness, take smallpox for instance, someone with smallpox, when they could transmit the disease, you could see the pox. It was, you didn't have to look very hard. But with this disease, if you can transmit it without even knowing it, without even feeling sick,
it's a little terrifying.
It's a real stealth
and it's such a serious disease. It's not like the cold.
And
which you know.
We're looking at mortality that is in the percentage, 2, 3, 4, 5. It depends on how skilled the medical care is, how early you get to the hospital, how available it is. So what happened in China, what happened in Milan, actually in all over Italy, but it was in northern Italy, was that people came in, they weren't paying attention to this, they overwhelmed the healthcare system, and suddenly they couldn't handle it. It happened in New York. people weren't taking it seriously. And then seeing all this, people began to take it seriously. But the difference here is that this isn't going away easily. This is going to take months. And if we don't have any other intervention, it's going to take an entire world of people to say, you know, we can't see it, we can't smell it, we can't feel it,
right.
but we know it's there, and we have to do these crazy things. We have to wear masks, we have to stay 6, we're probably 8 to 10 feet away right now.
Right.
The windows are open to getting good ventilation.
Right.
We have to do that and not let our guard down for months.
And even after we get tired of it, and even after it gets frustrating.
And it's economically devastating.
Yeah.
Because if we don't do it, a virus needs a host that is susceptible.
Tell me one other thing before we get on to that. I mean, I think the other thing people don't understand, because they only measure mortality and say, oh, well, okay, it's just old people, or it's just comorbid people, or it's just 1%. It has terrible effects on other elements of our body, right? Other organs. So tell us more about that.
So with this infection, we don't really know enough about it because, you know, the longest term survivors are 8 months into it.
Right, and the more we know, the more horrible it is. It's not
I think the more we know, the more we understand. I think what we can say is that for many people, a mild infection is something that they tolerate and they get over it, quite often like a cold. But for people who get a little sicker than that, there may be long-lasting side effects, but we have yet to be able to understand them. Mm-hmm. And we're working this out. Interestingly, the people who've been in intensive care units that have been really, really sick, mm-hmm. some of whom have required lung transplants, but the ones that manage to maintain themselves, they appear to be getting better faster than people did without COVID-19. So it may be that your body can, in fact, reasonably expel this with very few sequelae. But we don't know that for sure. And if a disease affects 100 people, it's not a problem. But when it affects 100 million and 1 billion and then 6 billion people,
even if a tiny percent gets,
we're going to see funny things happening.
Yeah.
And that's what we're seeing with these syndromes in children.
Yeah.
They appear to recover from COVID-19, and then they develop a really severe vasculopathy.
What's that?
That's where your blood vessels don't function like they should, and you have enhanced clotting, and they block off.
Yeah.
And that's been what this illness appears to be in kids. So we don't really understand it yet. And even though it's, as I said, the longest it could be, this is the end of August, is been 7 months. Right. And for most diseases, we know about them for decades, if not centuries.
Right.
So we're learning as we go. And that's why, if you look back in January, people weren't sure about wearing masks. But when we knew that you could transmit asymptomatically, and we were understanding the mode of transmission.
Right, the aerosols.
This is not something you get by eating.
Yeah.
This is something you get by breathing.
And and I think that's the other important thing. People tend to say, less knowledgeable people tend to say, the scientists said this, and now they're saying that, and therefore science is unreliable. But this is a perfect example of how science changes. We learned that we said this at that point, and now we know better. So we say that. They were once saying you shouldn't touch packages. They was worrying that the virus the aerosol drops on substances, on paper, could still be transmissible later on. They learned that was not the case. So it was a case for a shorter period of time than they originally thought. So you can't say that because science changes, it's wrong. It's because science changes that it's right. It's open to improvement and have an evidence of new facts and different facts that makes it stronger, not weaker.
Right. The scientific method is, in fact, to say, am I right? And try to prove whether you're right. And when you're wrong, you admit that you're wrong, and you use that information to move forward.
Right.
And that's how all science, whether it's medical science or hard science like physics and chemistry, it's all built on the idea of answering questions,
improving
to understand how something works, and that understanding changes. And that's where science is different from politics. A politician who changes his or her beliefs is said to flip-flop, while a scientist who changes his or her beliefs based on new evidence is smart, because they're able to say, I now understand what's happening, and if it's in fact true, if I do this, that will happen.
Right.
And when they do the experiment and they do that and this happens, then in fact they know they're right. And that allows them to think about the next thing.
Right.
And that's what the vaccine people are saying. When you get infected with COVID-19, your body makes antibodies, which are things in the blood, and blood cells that recognize that as an invader.
Mm-hmm.
And then they build up an immune response. We know that in some people, that immune response eliminates the virus, they get better, they have no symptoms. In others, however, the immune response is worse than the disease.
Yeah, it goes into overdrive.
You called in the National Guard to help with an insurrection, and they ended up causing more trouble than benefit.
Yeah.
And that happens occasionally in real life. It happens occasionally in the body.
Yeah.
So what scientists want to do with a vaccine is they want to develop a way to fool a body into thinking it's been infected enough so that if a real virus shows up, they say, that's a real virus. Whack!
Yeah.
I'm going to get it before it has a chance to multiply.
Yeah. So when you think about vaccine development right now, there are some ethical issues coming along with that. So how do you see the ethical problems with vaccine development?
There's a famous book written by Sinclair Lewis called Aerosmith, and it's not about the band, but it's about a physician named Martin Aerosmith who develops a serum to prevent an infection. And he is called to a mythical island in the Caribbean where there's an epidemic of this infection that his serum is aimed at. And he goes to this island and he starts treating people, and originally he sets up an experiment where he treats some people and not others.
Which is the way science usually tests vaccines,
so you know
right?
whether your drug, or in this case your serum, actually worked. But he sees so much illness, he can't do it. He treats everybody. And eventually he doesn't learn what he needed to learn. But the outside world thinks he stopped the infection. Because the infection stops on this island.
Yeah.
He's never sure. And that's kind of one of the key parts of the book. It's what we say in medicine is the Aerosmith problem. He couldn't bring himself to do the studies he needed to do. But here we are doing it now because we need to have a vaccine that's going to treat hundreds of millions, billions of people. We need to know whether it works.
Yeah.
And how well it works.
So are the vaccine companies at different stages of testing? And what happens if somebody gets to a vaccine that seems to work enough? Do you start to use that vaccine for mass numbers of people?
So where we are now is that there are a number of vaccines that have progressed through early stage development to show that when you give it to hundreds of volunteers, their immune systems have a response to it. Mm-hmm. Good news.
So far, so good.
And without a lot of bad side effects, either ones that patients feels or ones that we can see by looking at their laboratory values. So now we do the next step. Instead of treating hundreds, we treat thousands, tens of thousands of people. Some people get the active treatment. Some people get a control treatment, which has no activity.
Yeah.
And then we, in this kind of study, you just start counting cases. You vaccinate, let's say, 15,000 people in an area. Half get the active treatment, half get control. And 15,000 are getting each, and then you just count cases. Now,
and how long does that take, that whole
It depends,
process?
right? If you're in a place where there are a lot of cases, it doesn't take too long. Mm-hmm. If you're in a place where the cases are going down, it can take longer. With Ebola, for example, we developed a vaccine. We, being the medical world, developed a vaccine just as the epidemic was dying down on its own.
Because vaccine development normally takes a fairly long time.
It takes a long time.
And this one has been very accelerated.
Right. And it has to be, usually takes a long time because you're giving a treatment to people who are basically well, and you have a risk of making them sick. While now we have a lot of people who are at very high risk of being sick, and our economies, the world's economies, are being devastated.
Yeah.
And people are basically going nuts because humans are gregarious. They like to talk, they like to congregate, and suddenly we can't do all that.
Right.
And so the vaccine has social, economic, and medical needs.
Right.
And so we're pushing it like there's no tomorrow. So they're going to vaccinate people. In the study that I know about that's going on with the Moderna vaccine, and this is all public information, you can look it up yourself, is what they're doing is they're vaccinating the large numbers of people, and they gave them the first people got their first vaccination sometime in July. A month later, they get a second shot to kind of boost the immune system. We know that that really helps. And then it takes about 6 weeks after that for them to have full immunity. So that's 4 weeks for the first injection, 6 weeks afterwards, 10 weeks later. And then you start counting cases. How many people got sick that got the active treatment?
Yes, this whole process is
right. And how many? And so if there are a lot of cases, we get an answer. So those trials are driven what we call by events. So the statisticians who set the trial up said that when there are X number of events, we'll have enough to know. And if they're the same number in the active group or in the control
then
group,
it didn't work.
Then the vaccine didn't work.
Right.
If there are no cases in the active treatment group and lots of cases in the control group, it really worked.
And that looks like September before we know that.
I think it's going to be later than that.
Later
because
than that?
the first people got inoculated in July, but not everybody gets inoculated on the same day. It takes about 6 to 8 weeks to enroll 30,000 people. So it's probably going to be just around the beginning of November.
And then they have to ramp up, right? Even assuming they find something that works, something's got to get ramped up, and that's again where big pharma is.
Yeah. So the questions at that point will be how effective. Is this a 99% effective vaccine, a 90% effective vaccine, a 60% effective vaccine?
And what if it's 60%? Do we still use it, or do we say, well, let's wait for the 90%
60% we still use it. I don't know about you, but I got the first shingles vaccine from Merck, and then when the GSK vaccine came through, which was 90+% effective, I got revaccinated.
Right.
So I think that people, I think if we're at 60% effectiveness, people would use it, but we'd still have to practice social distancing and use masks.
Right.
Even after we're vaccinated.
The answer is there's really no acceptable solution on the near-term horizon. And even looking 6 months out, there's going to be only a moderate solution, and we're still going to have to be changing our behavior. And society as a whole has got to assume that it's in for a very long struggle.
On a scale of centuries, it's not a long struggle.
Right.
On the scale of our lifetime,
lifetimes,
it feels like forever.
Yeah.
And that's the problem.
Yeah.
But if this works, and let's say we have a vaccine which is spectacular success, 90% effectiveness, no side effects. We know that at the end of November, beginning of December.
Yeah.
You then ramp up production, not to produce 10 million, not to produce 100 million, not to produce 1 billion, but to produce 12 billion doses. You got 6 billion people who need 2 doses each.
Yeah.
You need a lot of this medicine.
Yeah.
Just to make 12 billion of anything requires a lot of work.
Yeah.
And then to distribute it. Right. And now we have people who don't want the vaccine.
Right.
Now, I can understand that you don't want the vaccine, but if you not wanting the vaccine hurts me, then that goes beyond what you're allowed to do.
Right. This is like kids going to school. You know, how can you count on herd immunity when the disease you're trying to herd against is this hugely deadly disease?
Well, I wouldn't call it hugely deadly, but it's deadly enough.
Well, hugely harmful, let's say.
Harmful, and it's something you want to avoid.
Yeah.
And nobody wants it. There were economies where they decided they weren't going to do much about it.
Right, Sweden.
Sweden and Brazil initially, and then their hospitals became overwhelmed.
They cratered.
And people suddenly, I see what you mean.
Yeah.
You know. Having all these people die is no fun at all. Yeah.
Well, there's going to be a lot of stuff written about this. Heaven knows.
There already has been.
Yeah, there already has been a lot of stuff from the socioeconomic and the literary point of view. It's the plague. I mean, it's the Journal of the Plague Year is yet to come, yet to be written for us. But I hope that we see a better outcome than we did in 1673. We'll see. Well, I mean, we wiped out half of the population, the Black Plague.
Right. But in Europe only.
In Europe.
Right. So the interesting thing to me is that if this had all happened in 1950, it would have stayed in China. We didn't have airplanes.
That's right. Isn't that interesting?
We didn't have airplanes. We didn't have all this. Right. So as the world's become more global, this is a consequence of globalization.
Yeah.
But who wants to go back?
Yeah, nobody. We don't. Well, Jeff, thank you so much. This is helpful. I hope that it helps inform people's thinking about what we need to do going forward. And I really appreciate your being here with us.
And we're in it for the long haul. So figure out a way to enjoy it, because if you don't, it's going to be really awful.
Good point. I think adjusting to all of this is the major job ahead of us, especially those of us over 55 who are really more at risk than anybody else.
Okay, Georgia, it's been good.
It's been good. Thank you so much. Thank you all for joining us today. I look forward to the next episode of Monday Scoop. Are there topics you'd like to know more about? Email me at mondayscoop@gmail.com. See you next Monday.